Welcome to this explainer on radiological safety. Listen, if you work anywhere near a diagnostic imaging department, you already know the deal. Radiation is an absolute game changer for diagnostics, but it's a tool that demands a tremendous amount of respect. Today, we're going to take all those complex physics and regulatory frameworks and turn them into actionable everyday knowledge. Right off the bat, picture this scenario. A kid comes in for a CT scan, but something goes wrong. Maybe a slight mispositioning, incorrect exposure factors, or just a simple lack of communication. The result? A non-diagnostic image. So what happens next? They have to do it all over again. That means doubling that child's radiation dose. It happens more often than we'd like to admit, and it is exactly what we want to prevent. So to figure out how to stop unnecessary exposures like that from happening, here is our roadmap. We'll quickly cover the biological stakes, move into core safety principles, hit our 3 main defensive tools, talk about optimizing patient exposure, and then wrap up with monitoring and regulations. First things first, we absolutely have to distinguish between the types of energy we're dealing with. We've got ionizing radiation. Think X-rays, CTs, fluoroscopy, and mammography. These pack enough energy to actually alter cellular DNA, which obviously carries biological risks. On the flip side, we have non-ionizing modalities like MRI and ultrasound. Those don't have that cell-altering capability. Keeping this distinction front and center is step number 1 in patient protection. Now, to put medical radiation into perspective, remember that we literally live in a radioactive world. Mother Nature gives us a steady dose of background radiation every single day. Take potassium-40, for example. It's naturally occurring and it's everywhere, including our food. Get this. Eating just 2 potassium-rich bananas exposes you to enough background radiation that it could potentially trip an ultra-sensitive nuclear monitor. It's wild, but it's totally unavoidable. But obviously in the hospital, we're dealing with higher man-made doses. And when that ionizing radiation hits the human body, it can trigger 2 main types of biological effects. First up are deterministic effects. These only happen at high doses and have a very clear threshold, like skin burns or cataracts. Then you have stochastic effects. These are the tricky ones. They occur completely at random, there is 0 safe threshold dose, and they include severe long-term consequences like cancer. Because any dose carries a non-zero risk of a stochastic effect, we have to keep a tight leash on it. And if you want to know why managing this energy is so crucial, just think about the X-ray tube itself. When electrons slam into the metal anode at high speeds, only 1% of that massive kinetic energy actually becomes useful X-rays. What about the other 99%? It just turns into intense, dangerous heat. We are going through incredible technological hurdles just to harness that tiny 1% sliver of useful energy. Okay, so how do we effectively manage all this risk? Well, we rely on 3 core safety principles established by the International Commission on Radiological Protection. These are essentially our golden rules, and they have to happen in strict sequence. Number 1, justification. Every single exam must have a real medical need. If there's no diagnostic benefit, we simply don't scan. Number 2, optimization. If we do scan, we use the lowest possible dose. And number 3, dose limitation. We operate under strict regulatory caps to protect both our staff and the general public. Check out how these limits break down in real life. There's a massive difference here. An occupational radiation worker, like us, is permitted up to 20 millisieverts per year, averaged over 5 years. But for a member of the general public, their limit is strictly capped at just 1 millisievert per year. Oh, and of course, much lower limits apply to pregnant workers to ensure the developing fetus is fully protected. And that brings us to the absolute anchor of this entire explainer, ALARA, as low as reasonably achievable. ALARA is a balancing act. It demands we use the minimum exposure necessary, but, and this is a big but, without making the dose so low that the image is just a blurry, non-diagnostic mess. Because, as we saw earlier, a useless image just means a repeat scan, which completely defeats the purpose. ALARA means hitting that perfect sweet spot between diagnostic quality and minimal risk. So, how do we actually pull off ALARA in our daily workflows? We use our primary defensive toolkit: time, distance, and shielding. First up is time, and this is just simple math. Exposure equals exposure rate times time. When you're doing continuous procedures like fluoroscopy or angiography, keeping your foot off the pedal and minimizing exposure time directly reduces the dose, not just for the patient on the table, but for everyone in the room. Next is distance, which is honestly my favorite because it feels like magic, but it's just the inverse square law. Radiation intensity drops off exponentially as you move away from the source. Practically speaking, if you just take a few steps back and double your distance from the radiation source, your exposure doesn't just get cut in half, it plummets by a massive factor of 4. Stepping back is one of the smartest things you can do. And the third tool is shielding. This is all about putting a physical barrier between you and the X-rays. We use high atomic number materials that just eat up the radiation, absorbing and attenuating the beam. Think structural stuff like thick concrete walls and lead-lined doors, plus your personal protective gear, lead aprons, lead gloves, and thyroid shields. Never skip the shielding. All right, we've talked about protecting ourselves. Let's pivot to optimizing patient exposure, which is where things get really actionable at the console. As a radiographer, you have so much power over patient safety. It's a delicate balance. You want a high kVp so the beam can easily penetrate the body, combined with a low MAS to keep the total number of X-ray photons down. You absolutely need to collimate the beam tightly. Only irradiate the exact area you care about, and let automatic exposure control do its job. Plus, keeping an eye on your dose metrics like CTDI and DLP ensures that your pediatric dose reduction techniques are actually doing what they're supposed to. Getting this right the first time is exactly how we prevent those dangerous repeat scans. Okay, so we know all the techniques to reduce the dose, but how do we actually prove that our safety measures are working? That's where monitoring and regulations come in. For occupational monitoring, we use the TLD badge, the thermoluminescent dosimeter. It's actually a pretty brilliant piece of tech. Inside that plastic cassette is a card with phosphor crystals, usually calcium sulfate. When ionizing radiation hits those crystals, they literally trap electrons in a higher energy state. Later, when the lab gets your badge, they heat it up. Those trapped electrons release light as they drop back to normal, and the lab measures that light to tell you exactly what your radiation dose was. But guys, the badge is completely useless if you don't wear it right. You wouldn't believe how many false overexposure alerts come from terrible badge etiquette. You have to load the card correctly, wear it right at chest level, and, this is crucial, it goes under your lead apron. That's the only way it accurately records the whole body dose your shielded tissues are actually getting. And when your shift is done, store it in a non-radiation area. Do not leave it hanging in the exam room. Zooming out to the institutional level, safety is heavily regulated. Bodies like India's Atomic Energy Regulatory Board, or AERB, don't mess around. They manage compliance through systems like the ALARA portal. But I want to stress this. Regulatory compliance isn't just bureaucratic red tape. It is quality assurance. Having a dedicated radiation safety officer, doing mandatory QA testing every 2 years, this ensures your equipment is calibrated and working safely. It's all about proactive patient safety. So, as we wrap up this explainer, take a second to reflect on your own workplace. Ask yourself, is your department treating regulatory compliance like a boring legal checklist? Or are you guys actively applying these principles, time, distance, shielding, and ALARA, every single time you turn on a machine? Radiation safety really is everyone's responsibility. Let's make it an active, daily commitment to protect ourselves, our team, and above all, the patients who trust us with their care.